All right, let's go ahead and get going here. I want to thank everyone for joining us this evening. My name is Bethany Peebles, and I'm the Executive Director of the Consultation Department here at Art Optical. And I think we have a really fun, unique event tonight with our live webinar featuring MOONLENS, the myopia management contact lens design. I'm going to start by introducing our expert MOONLENS clinicians who are going to lead us through tonight's webinar. First, we have Dr. Bruce Morgan. He is the Executive Director of Research and Clinical Support here at Art Optical. He is also a fellow of the American Academy of Optometry. Dr. Morgan graduated from Oklahoma College of Optometry and completed a cornea and contact lens residency at University of Missouri in St. Louis. He taught and practiced at St. Louis for 10 years before transitioning to the Michigan College of Optometry, where he served as the Chief of Cornea and Contact Lens Services. Next, we have Dr. Josh Latotsky, who is a professor at the Michigan College of Optometry, and he earned his doctorate in optometry from MCO in 2004. He completed a cornea and contact lens residency at MCO the following year, and is currently serving as the chief of the cornea and contact lens services at the University Eye Institute. And last but not least, we have Dr. Chad Rosen, who is an associate professor at Michigan College of Optometry. He received his optometry degree from Pacific University College of Optometry, where he also completed a residency in the cornea and contact lenses. He then went on to complete 2 years of fellowship at MCO's Vision Research Institute. Chad is also a fellow of the American Academy of Optometry.
We're really going to kind of turn this over and start talking about topography a little bit, because it is so important. We really have to have good topography, and Dr. Latotsky is going to help us with a few pointers on how we capture that topography. And then we're going to go over live patient details. So Josh, I'll let you take it over.
I'm speaking on Dr. Chad Rosen's computer, just because the way we have our setup for the live patient, my screen is actually going to be pointed more towards the patient, where the patient is going to be after the fact. So this is Josh talking, not Chad. Like Dr. Morgan said, the calculator works really, really well, provided you have good data. So what I want to focus on is not necessarily analyzing how you properly troubleshoot a topography after the fact the lenses fit. It's more about getting good topography to be able to use that to get your lens order correct, to be able to use it as a good baseline to troubleshoot things down the road. So we know that corneal topographers are basically done using Placido's disc technology. And that's not something that's new. Placido's disc has been around many, many, many years, probably as long as Dr. Morgan. Probably even longer than Dr. Morgan. But what we're doing with topography is bouncing those light rays off of the corneal tear film, and the topographer is then analyzing how the mirror reflects back, or how the corneal tear film reflects like a mirror back, and it analyzes the separation of the rings. So I've got a few different topographers up there. On the left there is the Medmont. You can see that that's a small cone design topographer. It's got more rings in it. It needs to get a lot closer to the patient. So in order to get good images, we're going to talk about how you go about getting that lens or that topographer in there. In the middle is the Oculus topographer. That's another topographer we have here at the school. That's more of a large cone type setup. Doesn't have to get quite as close to the patient, but you can still run into problems if the patient has a really prominent brow, deep set eyes, big nose, that kind of thing. So we're going to talk a little bit about how to fix that too. And then on the right is the Atlas, which is one that's been around a long time. It's in a lot of offices, but if you look to that one and look closely, you'll notice it's got two different chin rests. And the two different chin rests are to kind of promote the patient turning their head to the left to analyze the right eye, to the right to analyze the left eye. And that helps the topographer get in closer and be able to get images without getting shadows on them. The Medmont also has similar issues. So we'll talk about that here in a second. So here's the picture of you from the side. You can see obviously the cone of the Medmont is much smaller than those other instruments. It needs to get in very close. This is the view that the patient has as they look down the center of the tube. That's what they see. And then our assistant here, Andrew, who's a 6-year-old, is going to show us kind of how to get into position. And you'll see as he goes in there, I have him turn his head to the left. he goes a little too far at first. I don't need him turn that much. So he turns back just slightly, just a slight tilt. That lets me get in really close because that's where I need to be able to get the image. Some patients with deeper set eyes, you might bump the brow a little bit. You might bump the cheek. It's important to let them know that that's going to happen. You're not actually going to touch the eye, obviously, but you need to get that in there fairly close. As the patient looks down to the end of the tube, you want them looking down the center of the image in the center circle there. You'll see in this image, there's a blue light to the right side of that topographer unit. That is actually a mirror. A beam is being generated from the other side of the instrument. And what's actually happening as the instrument gets closer to the patient's corneal apex breaks that beam, and it tells the instrument how close it is, and it's going to tell it when to start acquiring images. And why that's important is because not only do we need to get close to the patient, that's why they're turning their head, but also if they don't have their lids open wide enough, the lashes can cause the topographer to not take the image. So I would say multiple times a semester, we'll be sitting in our attending room and the student will come to us and say, the topographer is broken, it won't take an image, the beam's just kind of bouncing around. And we usually say, we'll just have the patient open their eye a little bit more, that'll solve it. And they say, well, I already did that. And it's like, well, try again, open a little bit more. And sure enough, once they get the patient's lids open, the image works just fine. So really important point is to make sure the patient has their eye wide open. We're going to get the most amount of data. It's going to make it the most accurate to be able to put into that calculator that Dr. Morgan just shared with us. So as we're lining things up, this is another thing the students like to make a mistake on. Now, from the operator side, we see this green runway. We want to put the center target on the center circle in there. And as we get closer to the patient, that corneal apex breaks that beam and the red line is going to move down. We want to get the red line centered on top of the green target line, and that's going to tell us we're in the proper position. If we're too far away, like in the upper left there, the red line is far down the runway. If we get too close to the patient, we'll see it way down in the bottom. What happens if they're not holding their lids open wide enough and they're blinking is that red line is going to bounce around and the instrument won't take the image. So it's really important to kind of get things all lined up perfectly down the center like this. The instrument's going to spit out numbers like it shows in the bottom. The numbers tell you how well you are aligned are. They don't tell you how good that topography is. Our students often make that mistake as well. They tell me, well, it's obviously a good topography. I've got a 99 or 100. But that's not what's really going to tell us what the best topography is. We're going to talk about that here in a second. That's just how well aligned you are. Yes, you want to be aligned. You want something in the 90s, preferably even high 90s. But the bigger thing is how good the ring quality is within that at the same time. So I'm about to show you how you take an image here. We'll center things up. Patient looks down the end of this to the end of the circle. I get the target on there, and you'll see as I get in a position, I get the target centered. As I bring it closer, we're going to get that image on there. And as we get centered up, it starts to spit out images for me. Now, in that view, you'll see that we have a 97 and a 95. And as I was taking that image, I was also looking at the quality of the Myers or quality of the rings within that pupil. I saved them. If you're not sure which ones were good ones, you can use the zoom feature to kind of zoom in there to make sure that all those rings look like they're pristine. If you start to have the rings breaking up, the topographer gets confused. Like I said before, it's using a known distance for separation of those rings to determine curvature. If the rings get closer together, it thinks it's steeper. If the rings get farther apart, it thinks it's flatter. So if we have debris in the tears or we have the tear film breaking up and it's not getting a good reflection, we're going to have a problem and it's going to give us bad data. And that bad data can lead to trouble with troubleshooting down the road using the baseline or trouble getting the initial calculator accurate. So we'll talk a little bit kind of about that with common mistakes that we see. And the most common problem we have is what we call ring jam. And ring jam can be caused by a variety of things. In keratoconic patients or patients that have had corneal transplants, scar tissue really affects the topographer's ability to get good images. So you'll see some weird Myers across scars. There's not a whole lot we can do about that. In really bad cases, if you're trying to get curvature of a keratoconic just to try to get a starting lens fit, I've seen people put low-powered soft lenses on to kind of mask some of that to get a little bit more of an image. In Ortho-K, we're probably not worrying about so much about scar tissue, otherwise we wouldn't be doing an Ortho-K lens. For Ortho-K, it's more about the tear film breaking up or possibly about epithelial tissue being lost. Mainly at like day one, we might see a little bit of punctate staining. We might struggle to get a perfectly pristine set of rings on somebody at day 1. But what we're mainly focusing on now is getting a good baseline topography. So obviously the one on the left, there's all kinds of distortion within those rings, and that's all due to the tear film. If this is a live video, you can kind of see those things fluctuating as they go across there. The instrument's going to get very confused and is going to give us a very weird topographical map if that was what was going on. Now, the one on the right is much more minute, and so that's why I have that circle there. We can see a small amount of ring jam up there. Up on the top, there's another little spot. I didn't circle all of them, but those are all going to give us error points in the data, and it's going to make it tough to tell what's going on down the road if we're going to use this as a good baseline. This is a patient that has pristine tear film, and depending on what image or which map you saved, you can either have a really good one like the one on the left, or one on the right that's starting to break up. And now we're very subtle. Compared to the last images I was showing you, there's not much different there, but you can see the rings don't look quite right. But if you were watching it live, like I will in this video here in a second, it'll be a little bit more obvious. So as I play the video, we've got them pretty much aligned the whole time. The patient's got good fixation. If you took a map and saved it from one of these, you're going to get a good map. But watch over in this portion here as that tear film starts to break up. We get a subtle break of those rings, and that's going to give us a little bit of artifact in our data. Now, is that enough to mess up the ability to use the calculator? Probably not, but if we can save the pristine image, the one when it was on the left side of the view versus the one that's on the right, we're going to have a lot better data. It's going to be a lot better going forward for us. So just pay really close attention as you're doing that to make sure that the Myers look really good. If they're not looking really good, things you can do, I like to use a non-preserved, very low viscosity artificial tear. You don't want to put anything too viscous in because sometimes that can cause some artifacts as well. It may take too long to clear, but put a drop of low viscosity artificial tear in, have the patient blink a few times and see if that clears it. Sometimes just blinking alone clears it, so you can kind of see fluctuation as they blink. But you want to make sure when you go to save the image, you're saving one that's got the best rings possible. So here's kind of showing a patient with tear breakup. This is the same image taken a few seconds apart, similar to that last one. On the left is how that patient should look with a normal with the rule astigmatism. On the right, we can see the Myers are real distorted here because the tear film was starting to break up, both where that blue spot has been labeled and where the red is. You can see how trying to use that image on the right as your baseline would make for a mess of putting that into the calculator. It would also make for a mess of trying to use that for troubleshooting down the road. Now, here's what happens if you put too much tear in or try to take it too soon. On the left, if you look closely, you can kind of see a reflection of our rings down there in the lacrimal lake. This patient has too much tears going on there. We need to wait for those to dissipate. We'd also like to see the lid open a little bit wider, but we get a very weird distorted topography versus what that patient's actually is on the same last image. That should be how it should look on the left. And that's what we're getting because there's so much distortion from the excess tears. I take the color off anytime I don't take the topography myself. If the students take it, if another doctor has taken it, I want to make sure things look right before I start using that as my interpretation. So I turn the color off. I can see the rings a little bit better. In this case, you can see the double reflection, whether the color's on there or not, but it just makes it a little bit easier for some of the more slight amounts of ring jam, like I showed you, with the color off. This is a patient that is not looking down the end of the tube. Some of the clues to that are the fact that we can see this pupil looks way discentered in the image, but the image itself looks very, very strange. Again, once the color comes off, you can see that patient's actually not looking down the center of the tube at all. But again, if you use that as your topography, and that could happen, it would be a mess. Another big one we see, especially with the students, is not getting the patient to have their lids open wide enough. You know, the patient's not used to having people work on their eyes. They've got that tube really close to their face. It's a common reaction to kind of get a little bit squinty on you, but you'll lose so much data if that happens. So in this case, we've lost that whole superior portion of the data. That lens is going to be landing right in that area, and we won't really know what it's doing if we have to compare the baseline that looks like that to the right to what we're trying to troubleshoot with. So here's one from a few weeks ago. We had a 7-year-old patient referred in for Ortho-K. I sent my students to get the initial exam data, take a good look with the slit lamp, get a refraction, take a topography, and they came to me and they said, okay, we're ready to order the lens. Here's the image we have. Now, based on what I've shown you already, we kind of already start to see some of the artifacts. We've got our lids too squinty. We've got some weirdness going on in this bottom portion. It's like, is this an irregular cornea or is there something going on? When I take the color off, you can kind of see there's some ring jam going on down there. There's a little bit of excess tear possibly there, causing all kinds of artifacts. So the question becomes, was this a problem because it's a 7-year-old and they can't keep their eye open well enough? Or did we just not do a very good job taking the topography? The other thing you can note is that we're also getting it kind of flagged as being slightly irregular within the pupil, and that's caused by this spot down here. When we get a better topography in a second, you'll see how that goes away. So I sent my resident in here, and she knows what she's doing, and she got the image on the right. Substantial difference between the left and the right, but that's the same patient taken just a few minutes apart with the lids out of the way, patient not being squinty with good tear film. Now we're all green, we don't have any irregularity, and we have a good map that we can use as our baseline to troubleshoot down the road and also to order our initial lens. So it's very important, if you aren't taking the image and your technician is, or a student's taking it for you, to just double check what kind of data you have. Because like Dr. Morgan said, if you put garbage into the calculator, you're going to get garbage out. So what we're going to do next is transition over to some live patients and show you some lenses on eye. So I'm going to take a second here and switch cameras around, and we'll go from there.
So we're going to look at a few different lenses on eyes. We're going to make a few adjustments. We're going to go through some of the fluorescein patterns, see what we might see either at dispense for, a visit, or even potentially a follow-up visit, because we tend to use the lenses on eyes to troubleshoot a lot of times. So we always make sure that when our patients come, we tell them pretty much from the get-go, every visit that you come to, you need to bring your contact lenses, because there's a very high likelihood that we need to utilize those, see what that fluorescein pattern looks like. As Josh was just demonstrating, you can get a lot of information off of the topography, but it only tells you part of the story. So we like to use as many tools as possible. And if we can use what we're seeing on the topography to try to match up what we think that lens might look like on eye, it really gives us the information that can be most beneficial to the consultants that are the ones that are helping us trying to make the design and also make changes to the design in itself. All right, so we have a lens on. We're going to flush some fluorescein up and underneath there. It's always interesting too when we first get a contact lens on eye, how many times we've seen that, if a student comes back into the attending room and checks in with us, that they say, I really am not able to see any fluorescein. And the first thing we usually do, we'll say, well, how about we go and push the edge of the lens and see if we can get some fluorescein up and underneath there. And it's amazing to see their faces when they go, well, it didn't look like that when I looked at it. And, just pushing some of that fluorescein up and underneath, it's pretty easy to see that now we're able to visualize a little bit of a pattern here. And we're just going to hop over to the other eye just to see where we're at there. And then
I was hoping to be able to show you what I did. Because when I first looked in there, you could not see the return curve at all. It was pretty much looking like a corneal GP standard lens. But once I pushed a little fluorescein under there, you can see the return curve light up. If you look really closely, there's a really small bubble inferior temporal down there. That's not that uncommon to have a small amount of bubbles in the return curve, especially when the lens first goes on. That little small bubble doesn't worry me at all. As a matter of fact, I often will dispense a lens that's got a bubble that's covering maybe even a third of the return curve.
So when you're looking at this, you're saying that you would dispense with a small bubble. Just in the initial appearance, can you walk us through why it would make this lens dispensable?
We have a nice treatment zone. We have a lens that's fairly well centered. We've got good edge lift. That small bubble will eventually go away over time. It's maybe slightly low, but we know when the patient closes their eyes, they're probably going to develop reflex and the lid's going to probably roll up. So oftentimes what I'll have the patient do is kind of close their eyes for about 10 seconds. And then when they open, I want to watch where the lens comes from. So go ahead and open. You can kind of see that kind of came from the top. It was no longer down quite as low as it is right here. I don't get too upset about fluorescein patterns at dispense. If it's down slightly, we'll know it in the topography the next day. So I usually want to see what's happening after the end of a week or so before I really start making a lot of changes, especially with one that looks pretty good like this.
Yeah, and when you look at that, one of the things that I usually will say too is just start from the center and work your way out. So start with, we know the different curves to the lens. The lens, if it's not completely decentered off the eye, I look in the center of the lens and say, what is not only the shape of that treatment zone, but also the size of that treatment area, which is going to be that darkened central area that we see. And as we've kind of seen going through some of these other slides, we really want to see a fairly distinct transition from that central area where we see that darkened appearance out into that first portion, the innermost portion of that fluorescein ring. Because if we have a distinct transition, we know that we're not necessarily sitting too far off of the eye. If we're too far off of the eye, we're not going to get the shifting of the fluid between those cells. We're not necessarily as likely to get that correction that we're looking for. So that's usually where I start kind of working my way out once we get that image and I'm starting to walk through that with the students. Once we get out into that fluorescein ring, usually what I start looking for too is, again, I'm looking for how does it transition from one area to the next, but also what's the shape? Because as we saw when Dr. Morgan was presenting some of those slides, there can sometimes be a big difference between that, up and down that vertical meridian versus the horizontal, if it's a patient that has that withdrawal astigmatism. So if we have a nice round fluorescein ring, we know that the lens that's been designed is essentially fitting equally all the way around, which gives us hopefully the higher likelihood that we're going to get more of that treatment that we want, and that we can try to maintain centration of the lens as we're sleeping.
Dr. Morgan, you want to add anything to that?
Yeah, I would just say, I agree that we don't make any rash decisions on these fluorescein patterns, but it is important to make note of what the fluorescein pattern looks like. And so if it happens to be decentering excessively, this one isn't really decentering that much, but if it's decentering more, we still have to feel like, we're going to dispense it. And the best way to really view that fluorescein then is just to manually center that lens. Go ahead and manually center it and then read your fluorescein pattern. If it looks like a pretty good bullseye like this does, whereas if it's pretty much lateral or whatever, then there's still a good chance that when they sleep, that thing's going to align and do well because of that nice, distinct mid-peripheral band. See, that's where the fitting is occurring. See how distinct that band is? It's even all the way around. It's showing, really, really good alignment. And therefore, if you see, that in the ballpark, we're going to dispense it.
Yeah, I would totally agree. I would say when it comes to, probably one of the most common mistakes that we oftentimes will see that people want to make is making changes immediately. They'll, try to go for perfection on that very first one. And I mean, you've seen a lot of lenses in your day. How many of them have you seen that, yeah, they're not necessarily that textbook appearance on day one or, on dispense, but after they've worn that lens, whether it's day one or even a week, they come back and you're going, wow, yeah, that's doing exactly what we want it to do.
Yeah, a lot. Seen that a lot. So we really want to get a lens on the eye so that we can get a topography post fit. And that's really going to tell us really what's happening with the fit overall.
Let's hop over to the other eye and see what we've got going on there and whether or not we've got something similar or something different to talk about. Now, right off the bat, when I look at this other eye, one of the things that I'm seeing is when we first kind of swapped over is there's a little bit difference in the edge appearance. And I know that depending on the design you're working with, practitioners will say, well, there's way too much fluorescein on the edge. And, every design is going to be a little bit different. And when I look at this one, it looks like this might even have a little bit more edge lift. And honestly, when it comes to working with the MOONLENS, I feel like this is probably one of the lower amounts of edge lift that I see, because historically, MOONLENS tends to have a little bit more edge lift than what you might see with some other designs, and it works really, really well. And we've had lots of people wearing the lenses internally as well as patients, and comfort, the comment on comfort has been, well, this is an extremely comfortable lens, even if they compare it to other ones that they've worn. So, the edge lift might actually be playing a little bit of a role in it. So I'm not quite as concerned if I see even a little more edge lift than what we've got up in front of us on the screen right now. Dr. Morgan, do you want to comment on that at all?
Yeah, I agree. And again, if you're looking at that band, if that is distinct in 360, then yeah, you can really, let the edge lift go a little bit. But again, make note and say, well, we might have a little bit of excessive edge, because you may be able to use that in the future if you need to make an adjustment. So we just describe the fluorescein pattern, and this one's moving a lot. And again, movement is going to be variable because of lids and because of tear film and et cetera, et cetera. So again, if you have to center the lens manually, you can do that. And if it looks good, let her rip.
This patient literally just fit today and hasn't really acquired a adaptation to the lens just yet. So there's probably a little bit more tearing going on.
So would you guys use anesthetic when you're putting a dispensed lens on for, like, say, a child especially, or what are you guys doing now with that?
I normally do, mainly the way the process works with us. I do for one, helping the students be able to get more comfortable putting lenses on, especially a kid, because oftentimes they're a little anxious working with children. But two, I want the child to experience that lens, and they're going to after the anesthetic wears off. And by the time I get in the room and have talked to the parents and looked at the lenses, we've essentially gotten the anesthetic to wear off mostly, and I can then watch how that child is kind of reacting to it. So I feel like they get that more gradual experience of it. So I generally am putting anesthetic in with kids on that first visit or at that dispensing visit, because I want to make sure that I can evaluate that fluorescein pattern without them completely tearing up and not giving me the information that I need. Josh?
I think it's somewhat patient dependent. If I think the patient's going to have some issues with it, for sure, if they're going to be excessively tearing, I can't see what I need to look at, and that's not going to work. And it's also going to make for a bad experience for the kid. I've had kids that have come in that have been more established soft lens wearers that maybe have a little more tolerance to the lens in the eye. And at that time, I don't necessarily have to put the anesthetic in. So that'd be my take on that.
Yeah. And, and kids are going to be more sensitive overall. And so even though this lens is large, it typically doesn't move that much. Kids will often say, yeah, boy, this doesn't feel too good. So I always have the patients, especially kids, close their eyes, and then I ask them, now, how does it feel? And it's always greatly improved, of course. And then I tell them, well, that's how you're going to be wearing it 99% of the time. And they seem to really relax at that point, knowing, oh, okay, I think I can do this. And kids are really more resilient than you think. If you can get them over the hump, and I think, we've had a lot of kids in the clinic who initially might even be screaming like most kids in pediatric clinic. But once you get them past that hump of, understanding that it's not really going to hurt and it's really just kind of a sensation, and they wear the lens, then most of the time they come back and say, yeah, I'm doing great. I'm not having a problem.
When this lens first went on, there was a few larger bubbles in the return. They've since broken up, and we got a little bit of dipple veiling right there. It's subtle, but it's there.
And the return zone looks quite narrow. That's the only thing on this, but that could be a little bit misleading. Again, not getting enough fluorescein under there initially, but that would be the only thing that I would take note is maybe a little bit narrow of a return zone. And if we were going to see if you get more in there, you can see it widening a bit.
Part of it is, the camera only picks up so much through the slit itself. With my eyes, it looks pretty good. It looks more like this, if not even a little bit more.
Yeah.
Without doing so I think that's a little bit artifact from the camera. The dipple veiling doesn't worry me at all. I just wanted to point it out in case anybody saw it and was wondering what that was.
Right. Very common.
Yeah, any final comments regarding this particular set of lenses that you want to go over?
Not for me. I think basically you're making that decision. Am I going to dispense this or am I not? And 9 times out of 10 or more than that, you're going to dispense it.
This one is the easy decision for me. You look at it and you go, oh yeah, go ahead. That's a good one to let go for that first night. I mean, there's, to me, not any question about it. Let's see what happens on day one, and then decide whether or not something dramatic has occurred to where we do need to make a change, or if we're going to let it go for that extra week. So, as we're kind of transitioning and we're going into we're going to look at a couple other lenses. We'll get an idea then of what type of changes we might make if we need to make them. While we're doing that,
Chad,
yeah,
I just want to hop on for a minute. I know we said we were going to do questions towards the end, which we definitely will. And we've got some great questions. While you're doing this transition though,
yeah,
one of the attendees was a little bit concerned about the lenses because they were sitting a little bit low. And the left eye seemed to be sitting a little bit lower than the right eye.
yeah.
But if you guys could just go over that one more time, because I'm in complete agreement with you, I would definitely be dispensing that lens. And sometimes the lens position in the slit lamp can be a bit misleading. So if you can just give us some feedback on that, that would be great.
Absolutely. When we were looking at the lenses, especially since Dr. Letotsky was saying this was literally dispensed today, so not a GP lens wear or anything like that. Anytime you get some of those patients that maybe don't have quite as much exposure to contact lenses, the eyelid is going to knock that lens around a lot. So it's going to take a little bit of time just for them to get used to wearing lenses in general. Oftentimes with Ortho-K, a lot of times we'll see that because the eye or the eyelid is going to push that lens down a little bit. And, sometimes we'll see them actually farther down, and you might have somebody, especially a child, that has really tight eyelids. So that's where having them sit back, closing their eyes for, 10 seconds, 20 seconds, whatever your preference is, just giving them a little bit of time to have their eyes closed. And then make sure that once they immediately open their eyes, you can get an idea where that lens is. Obviously, the longer they sit there, the more information you get, but we feel we get enough just by having them do that in the chair. Most of the time, again, since we know that eyelid is going to push it down, we're not as concerned unless we start seeing that on their follow-up visits of, oh, it is decentered inferiorly when they sleep. Because again, to us, it's going to be definitely more important. How is that lens sitting when they're sleeping rather than right away in that slit lamp? So that's where a lot of times we do have to manually center those lenses and say when it's centered, it looks like the exact pattern that we want, even though it looks as though it's decentering inferiorly while the patient has their eyes open. So we kind of go through and we don't necessarily dismiss it, but we know that some of these things are going to impact it. And in that case, I would still want to see what that lens looks like after wearing it, because, I tell my students all the time, if you shoot for textbook on every patient, you're only going to have a few patients that you can fit, because contact lenses in general just really doesn't follow complete textbook. And, that fit right there was pretty darn good, I would say, especially for a dispensing appointment. That looked really good and is one that I wouldn't really hesitate at all to dispense. We're probably going to see some other lenses that are going to be more questionable. And that's where, I think the questions always come up on, well, where is the line that you draw of whether or not you dispense a lens? Because everybody always shows textbook fits, but they don't show the different fits that maybe you're not going to get exact appearance that you want. And then you have to decide where we're going to go. And what did we even put on this side?
No. Bear in mind, this one just went on, and I put fluorescein in, and there's a little bit more than I want to see. You'll start to see that central pattern maybe popping through just a little bit now, but obviously that looks a lot different than the last one I showed you.
Yeah. So now, if we compare the two, hopefully most people are going, oh yeah, I would definitely have dispensed the last pair.
This one's it's got good bearing out between the return and the edge lift portion. Centrally, there's a very, very small treatment zone, and the return is very, very wide. It's centered nice.
Yeah, so in this case then, when you're looking at that, you would naturally think, well, if the edges look really good and there's that good distinct transition from that landing zone into the reverse curve, then in that case, is the reverse curve just sitting the lens too high off of the eye? And do we have too much sagittal depth in the contact lens? I mean, that's what I would think. So
that's what I would think.
My intuition would say, even though, this doesn't look like that beautiful pattern that we see, and we can start seeing it come in more, it's still probably not going to drop down enough and have that fluorescein dissipate enough for us to go, yeah, that's the ideal fit. So in that case, I'd probably want to see something that's a little bit closer to the cornea or a little bit lower in that reverse curve. So when you get that RCD, I would probably want it to be a little less than what it actually is to see if we get that treatment. We're not, as to what Dr. Morgan was talking about, we're not really getting that completely distinct transition. It's kind of flushed as you go from the darkened area in the center into that fluorescein ring. You've got a few areas where it's a little bit more tapered, and it's starting to come in a little more the longer we have the lens on eye, which honestly is a really good thing to keep in mind. Depending on how you guys have your practices set up, you want to not necessarily evaluate the lens right after you put it on and right when you put the fluorescein in, because most people, what we find, tend to put too much fluorescein in, and you get a misconception because you end up having fluorescein sitting on the front of the contact lens, and it gives you a false fluorescein pattern. And we certainly had that with this one, since we pulled the slit lamp up immediately after putting fluorescein in. And now it looks quite different than when it first went on, when there was no darkened area.
You can at least tell it's an Ortho-K lens now. It doesn't
Yeah.
look good, but it's at least an Ortho-K lens again.
Yeah, it's getting better.
It is.
And that's where is that cutoff, for the treatment zone? Is it
Yeah.
2 millimeters, 3 millimeters, 4 millimeters? It's, somewhat depends on how much correction you're really shooting for. So that probably actually is a little bit borderline for me. It's certainly not ideal, but again, we're not in the business of making perfect pictures or perfect fluorescein patterns. We're in the business of trying to match and trying to treat that particular eyeball. And there's going to be some high-powered myopes that want to try orthokeratology, and you might fit them off label and come up with a fluorescein that looks like this, that you would say, well, I might let them sleep in this a night and see if it centers up. Because once you have things centered, then you're really in pretty good shape as far as making changes. But I would agree, I would be on the fence of dispensing. If this was like a one diopter myope, or I wouldn't dispense it.
Yeah, so I mean that's a great point, because the more correction you're going for, naturally, the smaller the treatment zone you might actually get on the cornea when you're taking the topography and evaluating it. We can only move so much tissue. But yeah, if you're a low myope and this is a -1, then I probably would say, maybe we want to see if we can get a little bit closer, because I think that the area that the treatment's going to be compressed in that cornea can be a little bigger than that. But it really is going to depend on your scenario for sure.
Yeah, and like you said, it's not a real distinct treatment zone either. So we're probably definitely off the cornea more than that 7 to 10 microns that would be more ideal.
Right. Yeah, but
It's
I mean,
fuzzy.
it is amazing to see the difference that you get just by sitting and watching it or having it sit for a little bit. One of the things is I love people that don't waste, and our students are really good about that, because we tell them straight up, I don't ever want to see you take that fluorescein strip and act like you're a painter. You're not a painter. You're an optometrist. And what do I see every time I see students put fluorescein on the eye? They paint it on, and then you end up with just way too much of it. And they give you this appearance or description of the appearance. And you go, well, that sounds really weird. And I go walking in 5 minutes later and it looks fantastic. And they're going, it didn't look like that when I was in there. And I said, yeah, it's because we have too much. So
would we be risking any damage to the eye or doing any harm if we actually dispensed a lens like this?
Nope.
No.
No, in this case, I mean, really, I guess my biggest concern would be, are we going to get enough treatment or a large enough treatment area? So if that's what I'm worried about, I wouldn't be worried, I wouldn't hesitate to actually let the patient sleep in it.
Yeah. And my guess would be that they would get some correction, and we'd get an idea whether we're getting centration. And so that's why I'm on the fence, because, especially with an empirical lens, you know, we're kind of guessing a little bit until we get to topography. We really want to get that first topography if we can, and that's really going to help us make then our some better decisions down the line. So again, I would probably be leaning just a little bit now. You know, it's a little bit more toward just letting them wear this one night, and then I can use the fluorescein pattern and the topography to tell me, okay, do we need to do something with the return curve, or do we need to do something with the you know, the base curve, or do we need to do something with the alignment zone?
Yeah, you know, it's always tough too, because we are not necessarily in a high population area. So we have a lot of patients that travel quite a ways to come and see us. So, you know, there might be some decisions that we make clinically that we say, you know what, these are the lenses we have. We don't have anything else. You drove 2.5 hours to come see us. Why don't we have you sleep in these lenses? And there are times where I might say, I'm going to potentially order a set of lenses that decreases that, you know, that
you can always do that.
And have them on hand for when you come back for your first follow-up. So, hey, if it doesn't work the way we want, or, you know, we're having any issues, we might have lenses available. So I don't generally use that as my go-to, but, you know, every situation is going to be a little different. And with having the edges on this look so good, you know, I'm not as concerned, and I'd be more curious to see how it centers.
And again, this is another time you can use your consultants. If you can take a photo of that, even with your cell phone, just anything to get to your consultant and show them what you're looking at, and they can help you make those decisions, especially early on when you're trying to figure out what is what. And so again, use your consultants, and taking photos and sending topographies are extremely helpful.
Yeah, let's move over. We're going to go into another lens. So we're actually going to say, let's make an adjustment and see what happens. And is the next lens, if I have it right, are we bringing it down a little bit?
It's a shallower lens, yes.
Okay, so we are decreasing the depth of the lens. So we're going to see if we get more of the impact that we're looking for, to try to get, I guess, a smaller fluorescein band. So we had one that was really thin, and now one that was a little thicker than what we might want to see. Now we're going to see if we can get kind of maybe the happy in between. Now, while we're changing this out, you know, we get questions all the time on what our methods are and what our follow-up schedule is with our patients. So what we will do is we'll do the fitting. We'll have the patient back once we get the lenses for a dispensing appointment. And at that appointment, we will do insertion removal training, make sure they know how to take the lenses out, put them on, and then we'll schedule a time for when they are going to come for their first visit after wearing the lenses. So we don't have them wear the contact lenses until the night before that first scheduled visit. And we always try to schedule our patients pretty much the first exam of the morning, because, you know, that first week generally tends to be the time of biggest fluctuation. And that first night tends to be kind of the toughest one when they wake up and you're forcing them to wear the contact lenses into an appointment. So, you know, we've had many patients that come and they end up having to drive an hour and a half to see us, and they got to keep their lenses on. So mom and dad are driving, you know, the child oftentimes, and I just tell them, wake your kid up, put them in the car and let them sleep until they get here. Because we really do like to see the lenses on eye that next morning, that first morning, to try to visualize everything about it. Is the lens stuck? Where is it sitting? What does the eye look like? Is it happy, unhappy? All of those things are really helpful for us because it helps us evaluate the health of the eye and how it made it through the night too.
Here's a good example of too much fluorescein.
Yeah, so we have definitely had too much fluorescein that we put in, and we just now kind of have to wait for it to dissipate a little bit before we get that true representation. But I mean, even when I took that quick peek right off the bat before we got more fluorescein up and underneath, it looked much better than what it does now.
Yeah.
Now we've got a bubble that's working its way around in that return zone. What are your thoughts on that, Josh?
Look, it's a smiley face. It's happy. That's about as big a bubble as I want to see. I've tried to force it out a couple times. It doesn't seem to want to go. I'm going to try to force it again, but I'm also trying not to push too much fluorescein underneath it to wreck our pattern. So it's not the end of the world, but I don't really want to see it any bigger than that.
Yeah, I'm usually in the same boat too. If you start getting something that's a third to a half of, bubble, that's a big bubble. And, you might end up actually having too much depth to that. And you're going to have potential comfort issues because patients, they're going to feel the bubbles. So smaller ones generally tend to go away. We're not as worried about them. If we can't force out a bubble because it's so big and it just keeps coming back, that might be an indication we need to make an adjustment with the lens. Now, if I get small bubbles, because there's lots of times we'll get multiple small bubbles that go around the edge. I'll either try to force them out, or what I will tell patients too is to assist in not getting air behind that contact lens. Before you put the lens on, put a drop of like an artificial tear or something in there, and then put that lens on. So if it's something that's constantly happening with a patient, I might give them that recommendation and see if that helps. And usually it's not really an issue. So this one's just interesting to see because it just kind of keeps moving its way. You can see it moves its way and spreads itself out.
Yeah, I would say under closed eye condition, that's probably going to go away in a matter of minutes.
And you can see additional ones coming and going, when you now look at that 7 o'clock position that it was at before. Now you've got a bunch of separate ones. And so I would think that this would naturally go away once they've slept in the lens.
Yep.
But you see that we've got a bigger treatment zone already. It's still not a perfect fit, but it's bigger treatment than the last one we had on the eye.
Definitely. Yep. That is definitely dispensable. That, the size of the return curve is not as, as exaggerated, and the definition of the treatment, see how much darker that, I know we don't have them side by side, but it's just a darker, more defined treatment zone than we had before. So
yeah,
we like that better for sure.
Yeah, for sure. I would be, and a lot of people will get focused on that bubble and say, yeah, it's there, but that's one of those things where if it's a smaller bubble, it generally is going to work its way out. But yeah, we can see
pictures side by side.
Yep. See that central zone? How
the one on the left is actually was when it was on the eye for a lot longer than the one on the right. I think the one on the right is going to get a even more defined zone the longer we let it go.
So I would definitely say, same thing. Left eye, a little more questionable, probably more borderline. Right eye or right side, I wouldn't worry about dispensing this. I think it looks much better between the two. Just if you're going solely by fluorescein, I would think we have a higher likelihood of success with this lens.
The other thing to think about is we're using Fluorescein tonight because the patient's being tortured and sitting behind the salon for extended periods of time. That'll soften the epithelium. That'll make some of this dimple veiling a little bit easier to occur. So don't get too upset about that either. Bubble's getting a lot smaller than what it was before. We're losing them. So that one's coming in pretty good.
Yes,
Dispense.
Exactly.
Dispense.
Don't go for that textbook.
And you may be adjusting this after a week or two, but it's definitely dispensable.
Absolutely.
Yeah. And then, if this is, if this looks at a 1 week or 2 week visit, again, you're going to have those topographies to look side by side and say, okay, is this an acceptable, fit? Because they just don't always, the fluorescein pattern does just not always reveal, what you're going to get. It just really doesn't. So if it's looking generally like a nice bullseye and you're getting some treatment and you've got that nice peripheral ring, we can make decisions later that are going to be more informed for sure. So let it ride.
Yeah, and if, to your point earlier, if you give good input, you're going to get a much better starting point with your contact lens. So you don't, it's amazing the difference that you can get by getting that good information and taking just a little bit extra time on that fitting visit. Because it makes it a lot easier when it comes to this type of scenario and you're wondering, well, should I dispense or not? Because if you can get a better lens on, it makes it a heck of a lot easier to decide. Yeah. So, all right, we're gonna try another lens. While we're doing ready for that, is there, Dr. Morgan, was there anything that you either wanted to go through or questions you've seen come through that kind of pertain to this? I know I started talking about our schedule.
I've got a few slides on that later on as far as follow up and what we talk about as far as how we treat uncorrected myopia in that first week or two, etc. But I think that those are things that are important to talk about. Bethany, are there any other pointed questions regarding the fluorescein patterns?
So there isn't really anything regarding the fluorescein pattern, but we certainly could answer while we're waiting. So there was one question that was curious about what fluorescein you're actually using.
For a while, it was whatever we could get our hands on.
Right?
Mix your own, yeah. Fluoresce, whatever.
BioGlow.
Yeah.
Pretty traditional single strip.
Perfect.
So yeah, we have BioGlow strips. We've had those for a while now. It was pretty crazy. We were told to limit everything, and there were areas of the clinic that didn't have any, and we said, well, contact lens absolutely has to have it because we use it all the time for.
The important thing is you can get, if you're using it on the same eye, you can use the strip more than one time.
Yeah, we use them multiple times on the same eye. So once we, put it on to begin with, we just set it back on the wrapper and you can keep using it. There's a lot much more fluorescein in those little strips than what you need, which is why students, or I always say students because that's who we work with most,
Sure.
But that's why anybody can just paint it right on.
Sure. So
this
yeah,
one's,
go ahead.
This one's got dimple veiling that's left over from the previous fit. That's not from this one. This is actually a spherical periphery lens as opposed to a toric periphery.
So now, different from what we had a couple of lenses ago, where we were talking about lenses sitting a little bit low on the open eye. This is one of those scenarios where the lens is sitting a little high. And again, the same questions kind of need to be asked. Is that how it's going to sit when the patient sleeps? And does an adjustment need to be made before we dispense a lens? Josh, what do you think?
Yeah, I mean, this one being non-toric, you can see some asymmetry in the edge lift. You can also see occasional little bit of bleed through in the inferior portion. It's getting a little better the longer it sits on the eye. I'll try to pull it a little away and center the lens without causing an artifact.
Yeah. Right.
But to me, we've been focusing more on trouble within the treatment portion. This one seems to have a little bit more trouble between the return and the landing. Every now and then you get a little bleed through again. This doesn't look bad, but that's the difference I see between this lens and the previous ones we have been seeing.
Yes. And when you center it, you definitely see a little bit more of that oval looking treatment zone. And so that's another indication that it may be, may need a toric landing or more toric a landing area. But once again, looking at that 360-degree band, it's not terrible, but it's definitely leaking oil some, in place. It's thinner here and up here than it is. So again, makes you concerned that lens is not going to line and center the way you want. If you don't get centration, then of course you're not going to get anywhere. So
we're going to have her close a second, and then when she opens, it should come from the top, I would bet.
Yeah.
It's up there.
Yeah.
This is one I'd be worrying a little bit about getting that smiley face in the topography.
Yeah, it might be a little bit difficult to kind of pick it out, but I'm trying to essentially draw around where her pupil is.
Yeah.
So as we're looking at the pupil and that lens, you know, the bottom of her pupil does come a lot closer towards the bottom of that treatment zone, to where, yeah, we might actually get more of that smiley face pattern.
And if I'm
Again.
gonna lose separation, I would much rather lose it inferior as opposed to superior. Inferior, you got the upper lid helping block a little bit of that, but inferior, that's really bothersome to have a smiley face.
But would you dispense that lens if it
Yeah,
was
I
if it was
would.
day one?
Topography shows me after a day or a week.
Yeah.
If there's anything that you can probably take away so far from us, MCO will just dispense any lens. But no, in this case, this is, you know, it's another one of those where it's very possible, because I have patients that look like this, where, you know, it looks like maybe it would sit superior, but when they sleep, the
It does.
lens sets perfectly, and you might adjust yourself out of a fit without ever get shot.
Yeah.
She's
So-
giving us a little bit more of a ptosis. She's probably tired of sitting behind the slim. She's actually shoved the lens down to center it a little bit better somehow. So.
Yeah. And yeah, so I would say really centration is really hard to, it's really hard to predict from a fluorescein pattern. It really is. And so you really need that overnight, if you can get it, to really don't start making changes in the design off of a one-day dispense unless they have no treatment or very little treatment. That's kind of what it comes down to.
You know, and it goes back to the comment that I made earlier. I personally don't believe you can do Ortho-K well without a topographer, because that really is what's telling you what's going on. You know, you can do a lot of Ortho-K dispenses and one-day visits, but if it's not going well, then where do you go from there? So that's where the topographer really, really is key. And it could show you that something like this actually is fine and works really well for the patient.
Very good.
Bethany, we cut you off. Was there something else that you were trying to either ask or express?
No, that's perfectly fine. We can wait for the questions till the end. I was just gonna fill that time when in between, but the fluorescein on this one dissipated pretty quickly, so that was good.
Yeah, and I mean, you know, if anything too, we can continue to see how much it changes after just
Mhm.
watching it for a few minutes.